دكتور هاني قال لي ان احنا هنتكلم على الاونكولوجيكال ايمرجنسيز، انا اخترت الحقيقه الموضوع الفبرايل نيوتروبينيا. One of the main causes of death in malignancy is infection. So it is very important issue to focus light on it. Febrile neutropenia, not only the oncologist who treat the patient or meet the patient with febrile neutropenia, actually internal medicine and the doctors in the ICU and in the ER, all of them faces the cases with febrile neutropenia. So the target audience may be most of the doctors, most of the specialties, because we are not only the doctors or physicians who are facing this situation. There is an increased risk of infection in patients with cancer that results for higher morbidity and mortality. Neutropenia represent a major risk factor for development of infections, especially in patients on chemotherapy. The factors that leads to infection in neutropenic patients is the low granulocyte count and also the disturbance of the mucosal membranes as an effect of chemotherapy. Approximately 50 to 60% of patients who became febrile have an established occult infection. Roughly 10 to 20% of patients with neutrophil count less than 100 will develop bloodstream infection. Usually the primary sites of infection in neutropenic patients in the alimentary tract, a lot in its treatment. And mortality of febrile neutropenia in one study is about 12.5%, which is a higher incidence of mortality. So we have to focus the light how to deal with this situation. In another study, mortality rates ranges between 3 to 20%, depending on the risk factors and other comorbid conditions in the patient. Usually the causative organisms may be gram-positive pathogens or gram-negative. It may be viral, and usually we focus on herpes simplex virus and herpes zoster virus and influenza and para-influenza. And lately, during the COVID era, which taught most of the physicians how to deal with infections and how to deal with isolation of the patient and how to protect ourselves and protect the patient from catching infections. Actually, it taught us a lot how to deal with this situation. And also it may be fungal infection as candidal infection. To define febrile neutropenia, febrile orally or equivalent or equal to 38 degrees Celsius over physical examination, history of prior significant infections, if the patient was on antibiotic prophylaxis or not, other medications, if the patient use devices. And this is very, very important because most of our patients, we use portally the site of port AKS may be the site of infection. So when we take also the blood culture, we have to take sample from the devices that we use to the patient. And also we have to ask about epidemiologically if there is other relevant exposures. Regarding the laboratory and radiological assessment, we have to go. Risk assessment of the patient is crucial in assessment of the patient in order to know if we gonna to hospitalize the patient or we will give the patient home treatment. Low risk situation, if the patient developed febrile neutropenia while he was at home and not at hospital, he has no acute comorbid illness. Also anticipated short duration according to the type of chemotherapies that we use. There is no hepatic toxicity or renal insufficiency. All these factors tell us that this patient is low risk and we can give him home treatment. So in cases like others, the hospital, we can admit him, when admit the patient in the hospital, we can admit him in the ward with isolation or ICU according to the situation and the other comorbidities. We usually start empiric therapy with, if we can start by monotherapy or combination. Actually, we usually prefer monotherapy. We can start with cefepime or imipenem or meropenem or piperacillin with tazobactam or ceftazidime. All of them are approved as first-line treatment, monotherapy, and in some cases, if we see that there is multiple or antimicrobial resistance based on the history of the patient or the patient in severe illness, we can consider to add combination. And remember, we don't start with vancomycin from the start. We usually go for vancomycin if there is indication for it according to the culture. If there is oral or mouth infection, we can go for